Hi everyone, it's your friend Doris the Coder back with another video. Today's video is going to talk about two modifiers, modifiers 25 and 57. So first let's define it. Modifier 25's significant and separately identifiable evaluation management service on the same day as another procedure or service by the same physician or other qualified healthcare professional in the same practice. And modifier 57, simply defined decision for surgery. So let's start. Before we talk about these modifiers individually, I need you to understand the surgical package. Now, if you reference page 72 of your CPT manual, this video is recorded in 2020, so it's page 72 of your professional edition, if that's the book you have. If you don't have the professional edition or you have a prior version manual that you're working with, you simply can go to your surgery guidelines in the very front of your book. This starts with the first bullet under the surgical package titled Evaluation and Management Services subsequent to the decision for surgery on the day before and or the day of surgery, including history or physical. So to really understand the intention behind both of these modifiers, you really have to have a basic understanding of what the surgical package is, bearing in mind that the surgical package can and does based on the payer change, right? So you could have a payer like Medicare, for example, that will expand the definition of the surgical package, and in doing that, how you report services can vary from payer to payer if the payer goes beyond how CPT defines the package, okay? Clear there. So now that you understand what the intention of the foundation for it being that surgical package, let's talk about modifier 25, significant and separately identifiable E&M. I am going to give you 3 facts, 3 myths, and 3 no-nos relative to modifier 25. I'm also going to give you probably about 6 tips that are going to help you to properly report this service. So let's first start with the facts only. The facts are, now you know what, I like to start with myths. So let's start with myths. One of the myths associated with modifier 25 is related to diagnoses. There are myths that you have to have a different diagnosis or you have to have the same diagnoses. Well, modifier 25 is not diagnosis driven as it relates to its intention by the AMA. What I can say is if you have a different diagnosis for which you're doing an evaluation and management service on the same day as a procedure, you probably have an easily supported, separately identifiable E&M. However, you are not required to have a separate diagnosis. You can actually use the same diagnosis as long as the pre-service work that you are performing goes significantly above and beyond the pre-service work required for that procedure. Okay, so that's myth number 1. Myth number 2, new patients. There is a belief, and if you reference your CCI policy manual, the section that covers E&M, the 90,000 series section, they actually explain this and make it very clear in no uncertain terms. Just because a patient is new to you as a provider does not mean you automatically get to report an E&M with the procedure you're performing. Now, strangely enough, on some of the Medicare administrative sites, at administrative contractor sites, they do not include new patients in the edit parts of procedures. So when you look at edits, it's not there, but you still have to understand really at a base that many of the surgical procedures throughout your CPT book have an inherent, when they value them, they actually include some level of E&M in them. And going back to those CPT guidelines, they're talking about kind of what you have to do anyway every time you do the procedure. So that's myth number 2. Myth number 3, unplanned procedures. So needless to say, it's already covered with new. If you've never seen a patient, you've not planned the procedure, right? But what if you have seen a patient before? So it's an established patient visit and you're doing a procedure. You might think, well, I didn't plan to do this procedure, and this procedure is the result of my E&M. After I, finished all the elements of that, I proceeded with doing the procedure. So I can report the procedure and the E&M modified. That too, you'll find dispelled in your reference guidance. Modifier 25 is not about diagnosis. It is not about timing relative except for the same day. It's all about documentation and necessity. Okay, so those are the 3 myths. New patients, diagnosis, and unplanned procedures that let's call those busted. Okay, now I want to talk to you about the 3 no-nos of using modifier 25. These no-nos are things that more likely than not it's going to be hard for you to support. Now, I'll give you these tips as I go to my next bullet too, and understand that every practice is different. But as a coder, if you understand how to apply these guidelines, you'll be able to at least assist your practice in uninviting, changing their patterns and uninviting risks to their practice. High modifier utilization. It's so bad, payers are now publishing on their sites. They're doing prepayment review for modifier 25. So if you do a procedure on the same day as a modifier 25, they're going to look at your documentation with the hopes that you clearly supported it, because they're not going to pay until they see the documentation for it. So let's deal with some no-nos, some things you really want to avoid so you don't find yourself in the precarious position of an audit that you can't defend. No-no number 1, E&M for a scheduled procedure. So for one reason or another, a provider may actually plan before they see the patient to do a procedure, right? In orthopedic, I did that for knee joint injections. Sometimes they have like Hyalgan or Synvis, and they were coming back for a series of injections. During today's visit, we may have evaluated the patient who was following up post-trigger point therapy. The trigger point didn't help. The medications aren't helping. The pains increase, so we scheduled the patient to get an epidural injection. The next visit is scheduled for an epidural injection. A number of different visits, right? A number of different specialties and reasons where you may actually plan a visit. If you plan the visit, understanding, and I'll go deeper into this later, that every procedure has inherent pre-procedure work, or put another way, things that you must do before that procedure every time to ensure it's safe to undergo the procedure. It is not advised that you bill an E&M. A good way for you to pick up as a coder, if you find that you're the person coding it, and every time, or you're just posting and billing, every time that procedure's done, there's always an E&M. Anytime there's an always, I get concerned from an auditing perspective, because if an edit was put in place, or if a modifier is required to permit payment where we normally wouldn't, and we're always doing something, it's hard for me to believe that you weren't kind of factored as a specialty in your habit. So be cautious with that. If you see that, that's something you may want to report to compliance, the office manager, the provider, and go with data. I'm going to do another video. I did a meeting today with the AAPC chapter in Modesto. I'm going to do another video about how to broach the compliance conversation. Well, stay tuned for that. No-no number 2. E&M services in multiple sites of service on the same day, right? So you can use modifier 25 when you are doing multiple E&Ms. You can also use modifier 25 when you are doing multiple an E&M in a procedure. So multiple E&Ms might be a patient who you evaluated earlier. And again, understand this is payer specific and some of them can freely override this. But let's say you evaluate a patient earlier in the morning in the hospital and they're relatively stable. They're in the hospital, but of course they're not unstable. You set a plan of care for that patient. Later that evening, that patient destabilizes or something else develops and you have to perform critical care. Well, you didn't perform critical care earlier because the patient didn't require it, so that may justify you doing a problem-oriented visit and critical care visit. Like if you can't, especially if it's a different problem, you can't address that at a single encounter, you can justify reporting multiple encounters on the same day. But if you have a situation where it's a patient seen in multiple types of service, so let's say you see them in the office and the decision is made to admit the patient, the provider admits the patient, sends the order, the patient goes to the hospital. Later that evening, the provider performs the H&P and actually has the face-to-face encounter on the same day. It would not be appropriate in that case to use a modifier 25. You've got guidelines that actually give you reporting instructions on how to capture that situation. And whether you're going from office to OBS or OBS to inpatient, you have instructions in CPT that actually kind of group your code and tell you to report kind of the ending service is what the guideline sums to. Also, if the other E&M service and your procedure are happening on the same day, on different dates, you don't need to use a modifier 25. because they're happening on different dates. Modifier 25 reads on the same day. So if the procedure or the other E&M aren't happening on the same calendar date, it's not something you really have to worry about. Another example for, and the idea is whatever procedure you're reporting has to not include the work involved in doing the E&M, right? So the E&M work can't be included in the procedure is what I meant to say, right? So let me give you another example. Let's say you code emergency medicine or critical care or hospital, any provider that bills the 99291 codes, right? So that provider performs CPR. Okay, perform CPR, patient comes in, they're not stable, they perform CPR, get the patient back, and then they have to work this patient up and figure out why did this patient come in like cardiac arrest, or basically we had to resuscitate them because they had abraded cardiac arrest or something like that. After the CPR is done, the provider orders testing, draws labs, tries to get whatever information they can from the patient if they're able to, even intubate, right? The CPR and the intubation, I can't count that. Now, the fact that they needed CPR and were intubated will help explain the condition part of critical care, where I can report that. I can support that they're sick enough to meet the critical care definition from a diagnosis perspective or a condition perspective. But I have to do more than the CPR and the intubation in order to justify billing critical care. So examining the patient, ordering diagnostics, reviewing the diagnostics, consulting or communicating with other physicians, that's all time work that I can count that would be separately identifiable from the intubation and the CPR. In that case, yes, I can absolutely report the critical care with the modifier 25, because I did more than just see that the patient couldn't breathe, did CPR and intubated them, right? I did significantly above that service in the reporting excuse me, of my critical care. So those are examples of E&Ms, E&Ms and procedures, and E&Ms and E&Ms, right? So two E&Ms or an E&M with a procedure. So those are the three modifier no-nos. So we've covered the myths, we've covered the no-nos. Now, when would we actually use modifier 25? And there's really three major things you want to look for. Number one, you want to look for global days. Okay, now again, bearing in mind that all procedure has inherent work. So even if you don't have global days, it would be correct coding to put a modifier 25 on an X procedure. So the first thing you want to do is you want to go to your fee schedule and find out how many global days does the procedure have. Global days can be 0, 10, or 90. If it is a 90-day procedure, modifier 25 is not what you need. You need modifier 57. They're somewhat alike in that regard, but one of the main drivers is, do you have a major procedure or do you have a minor procedure? Minors being 0 to 10 days, major procedures being titled as 90 or more. Okay, that's going to help drive you. Tip number 2, must have number 2, right? Or rule number 2, for lack of a better phrase there. So it's going to be that the E&M service has to be significant. It has to be far beyond the documentation or work required to do that work. And when you say far beyond, that's not kind of clearly defined. This is what I say to kind of help you understand that. If after you've removed all the elements that they do on every time they perform that procedure, if you, one, have something left and have enough left for those elements to stand alone, that is significant and separately identifiable. A lot of practices that get tagged with modifier 25 misuse also get tagged with upcoding. And why is that? It's because if you do not carve out the pre-procedure elements, you're essentially double counting them. You have to do them because of the procedure, and then you're counting them in the E&M level. Your E&M level could go down, could actually go up a level or two based on what those elements might be. Okay, bearing in mind, again, pre-procedure work is going to be different from practice to practice and patient to patient, and sometimes even provider to provider, which is why I wondered for a long time, why did we never get like a clear definition on what pre-procedure work is? And I realized after working in orthopedic and general surgery and IR and cardiology, some of my different, the work is different. And it's even different between practices, even dermatology. So I've worked in a few kind of surgical specialties, and it's different. This is why we can't get a definition, because for it to be defined, it has to be a unique standard. So I am going to include, when I get my tech skills in order, I'm going to connect a link to another video where I go on to a site and I help you kind of get your thought process going. If you don't have communication with a physician to help you understand what their pre-procedure works looks like, this should at least give you a baseline on where to go. And then the last piece that's important, so your E&M went beyond the pre-procedure work, significantly beyond the pre-procedure work required based on the documentation, and then you have necessity. So this is where cloning, providers don't understand that cloning is so disadvantageous for us, right? It doesn't help. It muddies the waters. When we're pulling and copying and pasting and forwarding things into documentation that is not specific and relevant to what we're dealing with in that day, a coder pulls out the pre-procedure elements, and now I have all these extra things left, and it looks like I can support an E&M. But then that third tip is going to be medically necessary, the medical necessity. So it may be for the same diagnosis or a different diagnosis. It really does not matter, but it must be medically necessary and supported in your documentation. Okay. So those are facts, myths, and no-nos associated with Modifier 25. What do you do? How do you properly report then? How do I know what's the test for me to know when I should use the Modifier 25? So the first thing you want to do is get your physician's pre-procedure work. There's a site I'm going to include in this video if I link that, so you can see what you can do if you don't have access to a physician. This will help you get your thought process going, but I find that I work best and fully understand it when I have a physician that I can dialogue with, because physicians are masters in the clinical, they're doctorates in the clinical, and we are masters in the coding aspect. So having those two spectrums covered keep the provider out of trouble. So first thing we're going to do, we're going to speak with our provider or elicit what pre-procedure work for the procedure is going to be. Then we're going to go through our documentation, and it's like when I did the coding, dissecting operative reports, right? Make it simple. I would just like mark out everything that was pre-procedure work, and then I go back to the note and code it, right? Do, things like affirming the problem that we have and we're dealing with. Checking for any contraindications, right? So every procedure may have some contraindications. Even if you were coming for immunizations, right? They would make sure that you weren't sick and didn't have a fever, right? Looking at the site and things like that. So the physician would take some level of history specific to the particular procedure that they're doing, things that may tell them this is not a good idea to do this procedure today. They would objectively confirm that it's safe to, right, by feeling the site, maybe taking vitals, assessing the site, things like that. And if a patient, and this is where I say you don't need a different diagnosis, patient's diabetic or they're on blood thinning or something like that, they may, for the diabetic patient, like take blood sugar. Right? Now, mind you, it's not standard of care for every patient. I don't need blood sugar just because I'm doing a steroid injection. But for a diabetic patient, a provider may find it necessary to take blood sugar, do like a little glucose check just to make sure, and kind of work on a plan to monitor the patient after that, knowing that they're diabetic and I just gave them a steroid, so their blood sugars might be a little bit off for a few days. Right? So it may require additional history from that patient to find out what do your blood sugars usually range, right? Because I'm about to inject you and I need to know what your baseline is, because if I know what your baseline is, I can better understand whether or not this injection is going to affect you. Because if your sugars are already running high, me having that data before is going to help to know what it looks like later and whether or not you had the impact I thought. So going through your note, pulling out all those elements that, or marking out the elements that are related to the procedure that's being performed, coding to see what's left, checking necessity to make sure it supports. And if it always looks like that for every single patient, then your provider has a more expansive pre-procedure work than another provider. It doesn't necessarily make it medically necessary. So this is why you have to look at, as a coder, look at the patterns in your documentation. If you are always seeing it, there's a reason they wrote the rules about the modifiers and edits, because they want it to be clear that it's common, and that's why you're always seeing it, and we may not have to get to report it, or may not be able to compliantly report it. Code those, get your levels. If you have enough to support, add the modifier 25, same diagnosis or different diagnosis. If you don't have enough to support it, you may did a little more work than an E&M, that procedure would typically require, but you didn't do enough work for it to stand alone. So did you do a separately identifiable service? Yes. Did you do a significantly separately identifiable service in the sense that it can stand alone? No, you can't use a modifier 25. It's really that easy. So that is the facts, the fiction, and the no-nos associated with modifier 25 and the rules. Modifier 57, I think, is a little more simplistic. Again, to understand it, you need to go to your guidelines, page 72 of your 2020 CPT book to understand it. Your guidelines related to E&M, when it comes to knowing that the surgical package says subsequent to the decision, put another way, after you made a decision to do the surgery, an evaluation and management service. Okay, hospitals have protocol with regard to what that timing looks like. So I think JCO requires that it's within 30 days, that there is an H&P within 30 days. And don't quote me on that, I could be wrong. I don't work in the hospital environment for or on behalf of the hospital. But I think I read in the regs maybe 30 days. So the hospital requires that the H&P be within 30 days. Well, realistically, outside of the kind of emergency kind of consulting environment, most providers don't take patients to surgery on the same day. Again, the demarcating point between 25 and 57 is global days. So this might be a patient with abdominal pain and vomiting that has gallstones, right? The cholecystectomy has a 90-day global. So I couldn't use a modifier 25 if they take the patient to surgery that day, because it's a major procedure. All right. Also, the difference with 25 and 57 is with 25, the procedure and E&M are happening on the same day. With 57, the E&M and procedure are either happening on the same day or the surgery could be happening the next day. So let me read it to you exactly the way it reads. It says, evaluation and management services subsequent to the decision for surgery on the day before or the day of surgery. Right? So you have a look back period of a day when you're dealing with a major procedure, because the 90-day, it's really kind of 92 days global, right? Because it's the day prior to surgery, the day of surgery, and 90 days post-op is what it really comes to. So look to your global period there, understand that it could be on a different day. And again, it's a little more straightforward. 57, unlike 25, says this is not the pre-op visit. It's at this visit where I did the actual, or today or tomorrow, I'm doing the actual surgical procedure. And it's at that visit that I made the decision to do the surgical procedure. It's not the pre-op, and should not be bundled. All right, that's the difference between the 57 in that regard. So that is it. That's all. That's as simplified. I said I wanted to get that. I am looking at like 23 minutes now, so that's where I am. Let me know. Thumbs up if you liked the video. If you found it helpful. I'm going to try to link a site to show you how you can help have a meaningful dialogue with your provider about pre-procedure work and determining what that is, because again, it changes. But if you don't have it, you're not dead in the water. I'll give you some tips on how to find it or how to maybe figure it out. So if you can gauge a conversation, maybe not with the providers, but with your compliance or someone else to kind of help you better understand and keep your practices out of risk. As always, it's your friend Doris the Coder. Thank you for visiting my channel. I load as often as I can. I'm not a person that has a schedule that I can promise you that I'll load every week, but hopefully you find the video helpful. And if you do, please share it with a friend, like, and if you want to know when I upload or be notified when I do that, feel free to subscribe. Thank you so much, and I hope you enjoyed the video. Have a good day and see you in the next one. Okay, so during this aspect of the video, as I told you, I would